Hi everybody! In this lecture, as you can see, we're going to explore issues of bioethics as they relate to end-of-life care. There are many different angles that one could take with this broad topic, but we'll be focusing on just a handful that are really more prominent in the news and also that may be more likely for you to encounter while working with terminal patients. Before we jump into all of that, though, we need to make sure we're all on the same page, that we have a shared understanding of some basic concepts and foundational terminology. What we're talking about here is bioethics. This is a field of study that looks at various ethical dilemmas or controversies that have arisen due to advances in medicine. Some of the hot topics in bioethics today didn't even exist 30 or 40 or 50 years ago when technology was more limited. Other popular controversies have existed for thousands of years, but they've simply changed shape or changed form over time based upon one's cultural and social beliefs and practices. Medical professionals encounter many different types of ethical dilemmas, and they should find comfort knowing that they don't have to handle them all on their own. Certainly the patient and family play a key role, and the physician does as well. And when necessary, they can also consult a bioethicist. This is a person educated in many different fields, as we can see here on the slide, and they can help the patient and family, as well as the medical team, navigate these difficult decisions and issues that may arise. When necessary, the dilemma may also be addressed by an ethics committee. So when we look at ethical dilemmas, what does that really mean? What constitutes an ethical dilemma, as opposed to just some sort of miscommunication or error? Well, what we're really looking at here has to do with how people conceptualize right from wrong. This notion relates to what one considers moral or immoral. This also relates to ethics in the sense that our morals guide our behaviors. However, ethics is not simply a matter of right versus wrong. There might be a right and wrong in some cases, but oftentimes the more complex cases involve situations in which there is a right versus a right. The patient or family may disagree with the medical team, and both of them have valid, legitimate concerns and positions. Patients don't have to do everything the doctor says. They absolutely have the right to refuse or explore alternative treatments, so we have to be very careful not to label people as non-compliant simply because they don't agree. Our job is to find out why. What influences their decision and their perspective on the matter? How can we better understand them? Then, how can we communicate openly to come to a conclusion that works both for the patient and falls within accepted ethical and moral practices? I also want to point out that ethics is not just a matter of opinion. We have opinions about all kinds of things. Your favorite color or food, even your favorite political candidate. But ethics is looking beyond opinions, and it requires us to formulate educated, informed positions on an issue. We need to have all the information in order to know how we really stand on an issue. Otherwise, if it's just opinion, it doesn't have anything to support it or hold it up. To help us evaluate ethical dilemmas and come to a conclusion or strong position on a matter, we can consider the 7 biomedical ethics principles. You see them listed here on the slide. Autonomy has to do with one's ability to make their own choices, free from coercion. Justice relates to not only what's fair or right, but it also looks at how resources are distributed, how people are affected, and who can access different types of services. Beneficence refers to the medical team having the patient's best interest in mind and trying to bring about good. Non-maleficence, on the other hand, has to do with the medical team not doing anything that would knowingly or intentionally bring about harm to the patient, whether through acts of commission or acts of omission. Veracity implies that both the medical team and the patient or family are openly and honestly exchanging information. It may be as simple as someone's symptoms that they're experiencing, or it may be as complex as explaining different treatment options. but people need to have all the information needed in order to arrive at a decision. Role fidelity means that the health professional is acting within his or her scope of practice and isn't doing things or saying things that are beyond their role or beyond their training. Finally, confidentiality deals with keeping people's personal health information private and only sharing information with those who have a legitimate reason to know, whether this be the other healthcare workers, an insurance company, or even extended family members. These 7 principles sound simple enough, right? Well, not always. And that's why we can use these concepts to evaluate situations and help come to a conclusion that is ultimately best for our patient. We also need to remember that elements of culture, society, and religion play a role here, and what one person considers best or right may be very different from someone else. They just have different ways of looking at the situation. Our job isn't to judge or make them do it our way, but rather to facilitate discussion and understanding so that we can help the parents achieve the goals, help the patient, it might be the parents, but help the patient really achieve the goals and outcomes that they're wanting, which might not necessarily be the same as what the medical team feels is best. This is easier said than done in some cases, which is why we rely not just on our own values and morals, but we can then look to our supervisors, to bioethicists, or ethics committees to help navigate these particularly complex cases. There are many different controversies surrounding the end of life. You could look at the front end, where life begins and potentially ends within a short period of time, such as situations involving abortion or stem cell research. Or you could look all the way to the other end of life when one is older. These may include debates around capital punishment, which is also known as the death penalty, or more common occurrences revolving around the end of life for someone who is chronically or terminally ill. Here we see discussions arise on topics such as futility in end-of-life care, rationing of medical services, euthanasia, and physician-assisted suicide, among others. But how do we come to decisions that are ethical? What things influence our positions on these controversial practices or options? Well, there's no simple answer, really. In fact, there are lots of things that impact the perspective we have on different issues. Everything from our morals and values, which are directly influenced by elements of our culture and religion, to social expectations about what is seen as good and desirable versus what may be seen as bad or undesirable. Certainly, there are oftentimes laws and legislation that guide our decisions, and there are oftentimes sanctions in place for those who do not follow the guidelines. However, just because something is legal does not always mean it is ethical. So you need to recognize that legal and ethical aren't exactly the same thing. Regardless, these different aspects of life all help us determine what is ethical or unethical, and as such, they help guide our decision making. So, to bring this back to our list of controversies surrounding the end of life, let's take some time to explore each of these just a little bit briefly. We're not going to do exhaustive research or comprehensive analysis of each, as that could literally be an entire class in and of itself, but we will look at some of the basic principles or arguments, who may be involved, and what different perspectives people may take based upon how they view the biomedical ethics principles. Let's start with abortion. There are different reasons why one may want to have an abortion, and there are different kinds of procedures that can be used to terminate a pregnancy. There are many ethical questions that arise, but two of the main ones include, is abortion ethical? And who should be the focus of consideration when deciding this? Do we focus on the mother, on the fetus or unborn baby, or both? Depending upon one's cultural, religious, and societal influences, as well as their individual morals and values, people may come to a variety of conclusions. Some people feel that abortion at any time is okay, that it's the mother's choice what to do with her body. Others feel that abortion is never okay and that abortion is equivalent with murder. Still others feel that it depends upon the circumstances. How old is the girl or woman? Was she the victim of rape or incest? Would continuing the pregnancy risk harm to the mother? Does the fetus have a genetic abnormality that's incompatible with life? Is the woman able to afford to raise this child and provide for it? These are all different questions and different perspectives that people consider when looking at the topic of abortion. Many people may be involved, beyond just the woman and the fetus. The father may be in the picture, and he may or may not be agreeing with the woman's choice to keep or terminate the pregnancy. The family is affected, as are the healthcare providers caring for the woman. Society at large is affected by there being either more or fewer babies born, which then has economic impacts for years to come. Of course, the legal system is involved, as abortion is legal in the U.S., but each state has their own specific laws regarding when abortion is allowed or not allowed. Usually these have to do with age for consent and how far in gestation the pregnancy can be for the abortion to legally occur. Most states outlaw late-term or third trimester abortions, and some only allow abortions within the first trimester. Certainly there are religious and political groups who are very outspoken, either on the pro-life or pro-choice fronts. When looking at abortion, all 7 ethical principles can apply, and you could really consider each from the perspective of the person or group involved as listed above. For example, think about how autonomy, or the right to make one's own decisions, may be viewed differently by the fetus, the mother, the father, the extended family, the healthcare provider, and so forth. I'd like you to push pause and really think about how each of these 7 principles may be looked at differently by those who have varying viewpoints or positions on this ethical dilemma. So again, you're thinking, how could different people look at justice when it relates to abortion? What's right, what's fair, what's legal? With veracity, how might different people involved really be looking at, is all the information really given to the patient? Is the doctor forthcoming? And on the flip side, is the patient forthcoming with the physician as well? Certainly with beneficence, what's bringing about the best good? Is it helping the mother most, the fetus most, the family most, or non-maleficence? If the idea is to do no harm, how does that look when you're looking at abortion? Do you say it's not harming the mother? It's not harming the fetus? That's one usually people could at least bring into question. Role fidelity. What is the role of that physician? Not all doctors have to perform abortions. They have the choice whether or not to do that, and so certainly people who are against abortion most likely would not work for a clinic or hospital that offered them. So what I'd like you to do is take some time, like I said, think about each of these principles and how various viewpoints may consider them differently. What principles are being upheld? What principles are being violated? So push pause, think about those things, and when you're ready to continue, push play again. Embryonic stem cell research holds promising results for millions of people suffering from debilitating diseases, such as Parkinson's, Alzheimer's, ALS, Huntington's disease, and more. However, these particular types of stem cells come from human embryos, typically either from aborted fetuses or from leftover embryos that were not implanted through the in vitro fertilization process. As such, there are different perspectives on whether or not embryonic stem cell research is ethical. To some, it's always ethical, as scientists are trying to promote good by making discoveries. To others, it's unethical because they don't think scientists should be playing God, and they don't feel that embryos should be destroyed for the sake of science. For others, it depends. Maybe it depends upon how they get the embryonic stem cells. Or maybe it depends upon what research they're being used for. There are lots of different perspectives, but these are some of the main ones. If we consider who's involved, we see not only that embryo or aborted fetus, but the parents as well. Did they give permission for their embryos or aborted fetus to be used in research? Do they know or have an opinion on what's happening? The scientists and researchers are obviously involved, and the healthcare providers as well. Not just the OB or fertility specialist who may have helped the couple with in vitro, or the doctor who may have performed the abortion, but sometimes that whole clinic or organization may be impacted, emotionally, socially, and spiritually. There are also legal guidelines involved, and these are still developing as new technology arises. Certainly, some religious groups are adamant in either supporting or opposing embryonic stem cell research. These cells are different from other types of stem cells, which can be harvested from living people, including their bone marrow, and so forth. So how do you think these ethical principles would apply? How do all 7 really fit here? And how might each look, different depending upon whose perspective you're talking about? For example, how might the scientist's desire for beneficence come into conflict with a person or religious group's values concerning the sanctity of life, or trying to do no harm, which is non-maleficence? When looking at the healthcare provider and the patient, is full disclosure given, which is veracity, so that an informed, autonomous decision can actually be made? There are all kinds of ways we can look at this. So again, because much of this lecture, the real value is coming from you being able to apply these different principles in various situations, I'd like you again to push pause and take some notes or jot down ideas about how we might consider these different ethical principles from various perspectives. How might the same principles be viewed in different ways? Push pause to evaluate these, and then push play when you're ready to continue. Ooh, here's one that's always good for debate. Whereas abortion and embryonic stem cell research deal with issues of life and death shortly after conception, capital punishment, or the death penalty, is generally only applicable to adults, at least in the United States. Do you think the death penalty is ethical? Why or why not? Some people say that yes, it's ethical, and they cite scripture, such as an eye for an eye, a tooth for a tooth. Or they look at it strictly from a legal perspective, because some states do still have legalized capital punishment, and some states do not. Others say that no, it's never ethical, because killing someone is never okay. Still others say it all depends. How heinous was the crime? Does the perpetrator show remorse? Are there other extenuating circumstances to consider? Does one's view really depend on whether or not they've actually had a loved one facing the death penalty, as opposed to someone who's just read about it or heard about it on the news or in the media? I'm sure it does, and this leads us into who all may be involved or affected. Again, we have to look beyond just that person who, in this case, committed a murder. They have a family too, as well as friends. How about the healthcare provider or the person who actually pushes that syringe or pulls that lever to carry out the execution? How are they impacted? Society is also influenced in many ways, both directly and indirectly, and certainly the legal system is a major player in these cases, or they wouldn't have been sentenced to death in the first place. There are also religious groups who take a strong stance either for or against the death penalty. I do think that all those 7 ethical principles do apply here as well. How do you see each of them either being upheld by carrying out the execution or potentially being violated through the execution? Take some time to think about this as well, and how it might be different depending on if you're the convicted murderer, their family members, the healthcare worker or prison employee, or someone else. So push pause, take some time to consider these, and when you're ready, click play again. Capital punishment was kind of its own separate issue in a sense, But these last few controversies that we'll be exploring are some that impact more people. One such concern that arises, and we've talked about earlier in the semester, has to do with the idea of futility in end-of-life care. In other words, when is enough enough? Do we have to follow this technological imperative that pushes us to do whatever is medically possible to prolong someone's life? Or does there come a time when invasive treatments are withheld? This is definitely an area with no clear black and white answers, but rather there's a lot of gray. It reinforces the value of having advanced directives, that's for sure. And there are many different perspectives, as we can see here on the slide. Maybe the patient chooses. Maybe the family or healthcare provider has more of a role in deciding what is or is not done. This may depend upon the family or the culture in terms of how they make decisions and how they view the healthcare provider. Some people want anything possible done to save someone's life, while others want only what may be necessary or actually effective. Sometimes it depends upon what type of life-prolonging measures may be in question. Are they talking about mechanical ventilation, artificial nutrition and hydration, dialysis, surgeries, medications? What's potentially involved will impact what decisions are made. This, of course, focuses on the patient and family as they interact with the healthcare team, but larger society is impacted as well. Not only in how the terminally ill or the elderly are viewed and valued, but also from a financial perspective. The most expensive care is performed at the end of life, and for people utilizing Medicare or Medicaid, taxpayers are paying in part for these cares to be provided. Religion also plays a role, as some religions want to do anything and everything, yet others want only what's natural, and many don't want to play God and either hasten or extend life beyond what God had planned. These are complex, difficult situations. Evaluating the 7 ethical principles can help us sort through these different options and different ethical perspectives. What influences people's choices? How might these be considered differently by the patient or the family even? For example, what if the patient is ready to die, but the family can't let go and wants to put them through all kinds of things the patient doesn't even want? On the other hand, what if the patient wants to keep fighting, but the family doesn't want to see them suffer, or they're worried about not being able to afford the healthcare services? What does the doctor think and value about life and death? So take some time to consider these. Look at each of those 7 ethics principles and how it might be viewed differently in terms of what's being upheld or what's being violated, what's that priority, depending on the different perspectives of people involved. Push pause to mull it over, and then click play when you're ready to go on. Rationing medical care is a similar concept. Futility of care says it's useless or not going to do any good necessarily to provide extensive, expensive cares when someone is not going to improve. Rationing is even more controversial in that it takes it one step further and says we shouldn't even provide care for people with specific types of conditions or who are beyond a certain age. This can take away their autonomy, even if they're able to pay. We don't see this happening as obviously or as blatantly in the U.S., although I'm sure it still happens at times. The question here concerns whether it's ethical to withhold or only provide certain amounts or certain kinds of health care based upon someone's age and health status. As with all the other controversies we've explored, we see many different camps or positions on this. Some say no, that rationing medical care is never ethical because all patients deserve equal access to all treatments. Others say yes, it's ethical to ration health care, and the doctors are best equipped to make that decision. Still others may say, well, it all depends upon what the treatment is, how much it costs, and how likely it is to be effective. What do you do if it's a scarce resource available to start with? We see the patient and their family, as well as the healthcare team involved here, in addition to society and taxpayers again. Legally, this one becomes more of a slippery slope, and we don't want to find ourselves in a situation where we're valuing one person's life over another. Who wants to say who can live and who has to die? That's essentially what this is looking at. In order to really explore this further, we can again consider the 7 ethics principles. For people who support rationing healthcare, what would they say is their strongest reasoning? For those who oppose rationing healthcare, what is their defense? What ethical principles would each side focus on? Think about it for a while, and then continue when you're ready. Now let's take a deeper look at euthanasia. Although controversial, it is not a new topic of discussion by any means. Much like abortion and capital punishment, euthanasia has existed for thousands of years. In Greek, euthanasia means good death. In English, it has taken the meaning of easy death or painless inducement of quick death. Is this practice ethical, though? Some say no, never, because it's murder. Others say yes, it's ethical if it's the patient or family's choice. Many others say that it really depends upon what type of euthanasia we're talking about. There's not just one kind, but rather we can break it down into 2 main types: passive euthanasia and active euthanasia. Passive euthanasia is when you allow a process to continue without intervention, knowing that it is likely the person will die. In other words, you stand aside and allow a terminally ill patient to die rather than doing everything possible to save them. You don't do anything to preserve or extend their life. This is generally acceptable when treatment is futile and there's no possibility of patient benefits. Every day, in hundreds of hospital settings, do not resuscitate orders are written in charts. Respirators are disconnected, IV lines are removed, and proposed surgeries are canceled. Even so, there appears to be a difference in public opinion between allowing someone to die and helping someone to die, even though the end result is the same. In terms of morality, some feel that allowing one to die is morally permissible, while helping one to die is morally wrong. Active euthanasia, on the other hand, requires actions that speed up the process of dying, or someone does something to help a person die sooner than they might if they were just waiting and doing nothing. Euthanasia can then be further subdivided into voluntary and involuntary. Voluntary euthanasia refers to when the process is initiated or requested by the patient. In other words, the patient is the one who is saying that they want to die. This is where the debate ensues, though, as to the question of whether there is a moral difference between active and passive voluntary euthanasia. Involuntary euthanasia, this last kind of category, is when a physician or other person brings about the death of an unwilling patient. Most would see this in a similar light to murder, and people, for the most part, are not supportive of involuntary euthanasia because it is morally wrong. How someone considers these different definitions or types of euthanasia thus impacts whether or not they feel it is ethical. As noted, when we're talking about passive euthanasia, or allowing someone to die, this can relate to futility in end-of-life care and could be situations that would benefit from palliative care or hospice care. But actually doing something to cause the person to die sooner, that's a little bit different. If the person wants to die, that's one thing. But if they don't want to die, but the family or doctor thinks they should no longer be living, that's a scary, slippery slope that involves not just patients, family, and providers, but all of society, including religious groups and the legal system. Certainly, all 7 ethics principles must be considered here. How might each of these be upheld through euthanasia? Or how might they be violated through euthanasia? How might opponents and proponents of euthanasia view each of these principles differently? Again, push pause, take some time to think about it, and when you're ready, we'll continue. Finally, we need to consider suicide or assisted suicide. With suicide, the patient brings about his or her own death without being coerced and makes arrangements to carry out their plan. While many doctors have been known to prescribe sleeping pills and pain medication for terminally ill patients who request them, knowing that their intended use is suicide, this is different because the doctor is not participating actively in the act of bringing about death. This would not be involuntary euthanasia or murder. Any physician who becomes involved in the suicide of a patient must first be assured that the patient is indeed in a hopeless situation and not just suffering from treatable depression, which is very common in individuals with a terminal illness. A great example of this debate and the complexities surrounding these issues is the infamous Jack Kevorkian. Prior to his conviction, one of the real problems was determining whether his patients died by suicide, whether he was practicing voluntary active euthanasia, or perhaps was murdering these patients. He is who many people think of when they hear the term mercy killing. Another person who became the face of the Right to Die movement was Brittany Maynard. A young woman with brain cancer, she very publicly shared her battle with an incurable brain tumor and moved to Oregon where she could follow the detailed protocol to obtain a lethal dose of medications from her physician. Her life and her death brought much attention to this issue and shed light on how personal a decision this really is. She obviously felt that physician-assisted suicide, or PAS as it's abbreviated, is ethical, but not everyone does. Some feel it's murder. Others feel it's up to that person. Many feel as though it depends upon their age, the prognosis, their mental state, whether or not it's legal in the state where they live, what method is used, and so forth. This issue goes far beyond just the patient, their family, and the doctor who oversees their care and prescribes the medication. The legal system, all of society, and religious groups are certainly involved as well. Much of this is also driven by Americans' individualism, or the desire to make one's own choices and have control over all aspects of life and death. This is seen as a viable option for some people, but as unfathomable by others. What do you think? Which ethical principles do you think are more important in either supporting the use of physician-assisted suicide or opposing it? Take some time to think about it. What if the patient and the family and the healthcare provider all agree? But what if there's disagreement, maybe between the patient and their family, or the patient and family are aligned but the doctor disagrees, or they live in a community where that's really not condoned? Think about how each of these ethics principles might be upheld or might be violated. Since euthanasia and physician-assisted suicide have been in the news more recently, let's take a couple of minutes to explore them in a bit more depth. This slide outlines the current list of countries that either allow euthanasia, physician-assisted suicide, or both. You'll notice that some have very specific caveats, and that's important to note. This prevents people from getting a lethal prescription for a condition that isn't really life-threatening, or is more situational. Let's look at the Netherlands, for example. The Netherlands, also known as Holland, is the only modern industrialized nation to fully sanction physician-assisted suicide. This became legal in 2002 and established a set of criteria that physicians must meet. The patient must request the assistance freely and frequently after careful consideration. The physician may act upon the request only if the patient is terminally ill with no hope of improvement or they're in severe pain. The physician must consult with another physician and file a report with the coroner. There was also a review period, during which time the police and prosecutor's office had to review the cases to ensure compliance with these procedures. Clearly, there are groups of people for or against this legislation, and many on either side of the fence view it as a slippery slope. Similar to the Netherlands, the Oregon Death with Dignity Act attempts to provide protections to ensure that abuses do not occur. The law requires that the patient be capable and a competent adult. They have to be an Oregon resident and have a terminal illness with less than 6 months to live. A voluntary request for prescription of lethal drugs is also important, as this request may be made verbally and in writing and then be signed and dated by the patient, while witnessed by at least 2 individuals, one of whom must be the attending physician. There are specific requirements on the part of the doctor as well, which I haven't listed in detail, but you can find online. Again, physician-assisted suicide is only legal in a handful of states. Many other states have legislation up for review and debate, so we will likely see more legalizing in the future. Interestingly enough, studies suggest that it's unlikely that the public's increasing acceptance of active euthanasia or physician-assisted suicide is based on any perceived view of autonomy based upon the person's right to die, but rather it's more likely that people fear a long and painful death in a cold, sterile environment, away from their family and friends. There are also concerns about finances, about being a burden to the family, and not wanting to end up in a state of unconsciousness that just lingers on. If this is true, then we should look at hospice again as another viable option for pain control and maintenance of dignity in life. The goal is to make terminally ill patients comfortable and have as high a quality of life as possible, rather than focusing on quantity or living as long as possible. Under hospice, the goal is no longer to cure, but to comfort, no longer to treat, no longer to treat the cause, but rather to ease the symptoms. For many, hospice has become the safe, legal, and socially acceptable alternative to euthanasia, whether passive or active. So as we wrap up this lecture, let's do a quick review. Our morals and values are influenced by our culture and religion, as well as societal expectations, laws, and related sanctions. These shape our perspective. They help us decide what we view as ethical or unethical. This has to be more than just our opinion, however, and we have to be informed of the complexities of these issues. By examining and applying the biomedical ethics principles and consulting with supervisors or even ethics committees when needed, we can arrive at decisions that help resolve ethical dilemmas. This can be very helpful as we navigate an increasingly diverse and complicated healthcare system, as we want to be sensitive to and supportive of our patients and their families as they face the end of life.